Good evening, learners. Welcome to today's meeting, which is the fourth part of our tutorial on amblyopia. Thanks everyone for attending. So welcome to every participant here, Dr. Nabeed, Dr. Aswathy, and again we have a new name here, Dr. Subeh, and our faculty, Dr. Vijaya. So welcome to all of you. It's good to see you again, and I think we are good now to go and start our presentation. Pre-meeting requirements as usual, but I have here a request if you have any questions or any comments, so please interrupt me. Again, the aim of this tutorial is to discuss rather than mere narration or cramming you with a lot of information. I have added this slide because we have a lot to cover today. So the faster you respond to my questions, the sooner we'll finish the meeting. All right. And here is the topics in our meeting or the agenda. So first, we'll add some more details about the lines of treatment we mentioned last time. And as I promised you, I will discuss some cases throughout the presentation. So there will be a kind of merge during the presentation, mentioning some cases along with lines of treatment. Followed by screening, and we are keeping Dr. Ashwati's assignment for the last. I hope we'll able to finish this presentation so we don't need to have like part 5. Again, to sum up what I mentioned in the last slides last time, because in medicine, particularly in amblyopia, we follow up the patients regularly. And again, the importance of screening, I can't say it enough. And we mentioned last time the benefits of treating amblyopia, to have like a spare tire, because there is almost a risk for bilateral visual impairment just in case the sound eye develop loss of vision due to trauma, particularly in this age group. And again, to improve the binocularity and improve the chances for having some jobs. And poor vision also can lead to secondary strabismus. So to avoid this cosmetic problem. Again, I categorized line of treatment into 5, treatment of the cause, and among them, spectacles for any refractive error, and penalization. And the most important one is combined, because sometimes, or most of the times, we need combined lines of treatment, and we have some others emerging lines of treatment. Try to familiarize yourself with these acronyms. PDIG is the Pediatric Eye Disease Investigator Group, which is a clinical network of pediatric optometrists and ophthalmologists funded by the National Eye Institute to conduct clinical research studies related to pediatric eye conditions. Because throughout this presentation, most of the information I will be presenting was taken from these studies. And these studies are collectively known as ATS, or amblyopia treatment studies, and they are given numbers. So we have ATS1, ATS2, and so on. And the American Academy has published a preferred practice pattern for amblyopia treatment. So I tried to avoid using I statement or to mention some of my experience in order to familiarize you with the evidence-based medicine regarding the amblyopia, but I shall add some of my experience as well. So we have some introducing slides before we dive deeply into each line of treatment. So whenever you have a patient for the first time, so you have a first visit, you should give parents or the caregiver a full document or a full report about the situation, about the condition. So I think you already know that I like to incorporate both simple and advanced knowledge during our presentation. So if you find some information are too basic, so bear with me. So first, patient's name, of course, and the date of first visit is really important. And again, the diagnosis. In pediatric clinic, we usually confronted with multiple diagnoses. And actually, this is very common in medicine. Because I run a strabismic clinic, most of the amblyopia I'm seeing are a mix of strabismus and refractive error. That's why I wrote here strabismus, and you have to clarify the type of strabismus, refractive error, and the type of amblyopia. All of these should be demonstrated to the parents and try to educate them about the diagnosis and the line of treatment or the treatment plan. So most of the time we have like three spectacles or patch. You have to specify which eye and for how many hours, and usually it is recommended to have near activities during patching hours. And I found in my practice that instead of saying to the parents to come after 6 weeks or 2 months, it's better to specify the date of the next follow-up visits. It helps in the compliance of the parents to regularly come and see you again. And it helps to avoid the dropout in the follow-up of patients. And don't forget to mention the signatures at the end, and it should be clear. So everything starting from the history taking until the diagnosis and the lines of treatment should be verbally discussed and written clearly and rechecked regularly. So you are giving the parents a lot of instruction about the line of treatments, and during each follow-up you have to recheck are they following the instructions given or not. And this is really important in the for effective treatment of amblyopia. And I know some offices give the parents a full report of the chart of the patient's file as well. So let's start our first questions here. What's the treatment window for amblyopia? We have A, up to 9 years of age, B, up to 17 years of age, C, up to 40 years of age. So excellent, it's B, up to 17 years of age. So thanks, Dr. Maisa, Aswathy, Naveed. The ideal treatment, of course, for treating amblyopia in the first decade of life. So you can previously choose, or traditionally or historically, up to 9 years of age. And the ideal outcome actually during this age group. But according to the ATS, amblyopia treatment studies, you can treat amblyopia up to 17 years of age. And maybe in the future, we can treat it up to 40 years of age, who knows? So this is the treatment window for amblyopia. According to the reference here in the slide, some 13 to 17-year-old children showing significant improvement with treatment, even with history of prior treatment, because there is some results that shows that if there is no history of prior treatment, the improvement will be better, but you can't judge whether they were compliant or not. So even if there is a history of prior treatment, you can treat or provide treatment for all the children up to 17 years of age. One should not withhold treatment for children aged 13 to 17 years, even with a history of prior treatment. All right. So we have two windows. We mentioned the word window twice throughout this tutorial. We have the window for amblyopia development. And if you remember, it was up to 7 years of age, 7 to 8 years of age. And we have treatment window, which is up to 17 years of age. All right. So I have a question for you here now. Actually, number 17 is important in the field of ophthalmology. So do you know why? Does this number remind you by something important in ophthalmology? So, you know, I go off topic sometimes, but it's a kind of breaks and brainstorming questions. We have 7 here, and we have 17 and 17 also. So we have here in the at the bottom of the slide. So the primary visual cortex, which is the Prodman area 17, and what is the coincidence? Because the primary insult here in amblyopia lies in the primary visual cortex and as well as in the lateral geniculate body. So during the follow-up, you have to document in your file what is the response to your line of treatment. And we have different possibilities. As you see here, I use the emoji. Some are happy and some are sad, some are angry. So let's see what are inside these steps. So it could be improving. All right. And then we are happy. Or there might be failure, or we can call it resistant amblyopia or refractory amblyopia. And of course, we are sad. And on keeping the follow-up, we are waiting for resolved amblyopia or resolution of amblyopia, and we can then celebrate. But sometimes some kids are improving, but then stop improving. We call it residual, and so we have like a residual amblyopia, or we can call it as plateau amblyopia. And again, we are sad again. And in rare cases, because we are no longer nowadays use full-time patch, we came across reverse amblyopia, in which the previously sound eye developed amblyopia. And this makes us angry, of course. And even the amblyopia is resolved, you have to keep follow-up for a while, because sometimes you may get relapse or recurrence of amblyopia. And there is an interesting word here, recidivism. So it's hard to me to pronounce it. So recidivism, it means simply relapse or recurrence. So how we can document the response, whether it is improving or there is not improving. So how we can document this? So here is a reminder. It depends on your diagnostic criteria for amblyopia. So for example, if you are able to check the visual acuity, so the best one is to follow the case using the best corrective visual acuity. If you are using the CSM system, if you remember, you can know the progress or the improvement CSM system or F&F system. You remember F&F system? So previously, the child wasn't not fix and follow well, and during the follow-up, he starts to fix and follow well. So there is improving. So I mentioned this table again from the American Academy last time, but actually this is the old version. We have the updated version here, or the latest table here. They added one row here for bilateral amblyopia. So if we have an age more than 5 years, we can diagnose bilateral amblyopia if the best corrected visual acuity is worse than 20/30. All right. So we can document the response by assessing the corrected visual acuity, or other systems that you may use in infancy, like F&F or CSM system. Or if the case has unilateral strabismus and during the follow-up started to alternate, so this is an improvement in the amblyopia. And again, during taking the history, parents may report that the quality of life is improving, the reading speed is improving, they can navigate very well during playing and on doing homework. So you can judge also during the history taking, of course, during the follow-up. And if there is no response or unsatisfactory response, so first think of compliance. So you can say this is a non-compliance until proved otherwise. And then if you are sure that these parents are very compliant, then question again your diagnosis and question again your plan. You may need to add a new line or other line of treatment. And if you remember last time, we practiced together the CSM system on those 2 kids. But this was for practice. But in this age group, we test the visual acuity. So we don't use the CSM system in this age group because they are old enough to check the visual acuity. But we use it as a demo to practice CSM system, because CSM system and FF system used in infancy mostly. And here is an important caveat. During the follow-up, generally, we depend on the best corrected visual acuity. So you may misjudge the condition, misjudge the response, because if there is some examiner to examiner variabilities, so some examiner are very keen or patient while assessing the visual acuity, and others may be rapidly or in hurry. And we have to keep in our mind that the attention span and the mood and health or the age of the child will affect the subjective testing of the visual acuity, because it's subjective. It depends on the child. And as the child grows up, they are become more cooperative, and the vision may be improving because they are growing up and become more cooperative. And again, you have to report the method of testing the visual acuity, because some optotypes are easier than others, and whether you are testing using the crowding or the contour bars or not. And here is an important one. So here is a case. So simply she has, as you see here, let's see someone talk here. Do you like to assign someone, or can someone volunteer? Just to describe the photo, because this is the kind of practice. Okay, Dr. Sana?
Shall I tell, ma'am?
Yeah, go ahead.
Okay. Here I can see a photo of a child wherein a Hirschberg test is done. And I can see that the right eye, the corneal reflex appears to be central. And in the left eye, there is an apparent exotropia around 15 to 30 degrees, as what I can say.
Okay, nice.
Yes, that's it, ma'am.
All right. And do you see the next one now?
Yes. Now the child is given glasses, and the exotropia, apparent exotropia is corrected, and the corneal reflex in both eyes is central.
Okay. Thank you, Dr. Sana. Well done.
Okay. Thank you.
So in short, she has an exotropia on the left side, and also amblyopia, and she's giving spectacles, and it improves her control over the exodeviation. But during the follow-up, as you see here, the OD is 1 and the OS is 0.7. So can anyone tell me what are these kind of notation? So OD is 1 and OS is 0.7. So what is this kind of notation? Or is it meter, feet, logmar, decimal? So she has a left amblyopia. If we have 1 logmar, what does it mean?
6.6?
No, because this is sometimes confusing, and it appears in exams, by the way, in the first part exams. If we see here in the logmar, 6.6 or 20/20 is 0 logmar, but 1 matches 6/60. So this is sometimes confusing, because we have 1 logmar, it means 6/60, but 1 in decimal means 6/6. So actually, if you remember from basics, decimal is actually it's like a fraction, it's like a math. So 20/20 is 1, or 6/6 is 1. So 1 here means it is in decimal notation. Based on the history, I'm telling you that the left eye is the amblyopia, so it should be the left eye is worse than the right eye. So the right eye is 6.6 simply, and the left eye is 0.7. So this is a decimal notation. And as you see, this is another visit. So here there is a decrease in the visual acuity, okay? Because in decimal, as the number goes down, it's worsening. And in the next visit, it's improving as it was in the first visit. This is confusing, right? And another visit, wow, it's now resolved. It's a resolution of amblyopia, because the vision here is 1. But again, it's back to 0.5. So what was the problem here? Actually, in my practice, I prefer to use the up and down, where the opening is up or down. So for her, it wasn't easy to differentiate the optotype, the opening for vertical and vertical opening, but it was easy for her to differentiate between horizontal opening. And this says something. So can you solve the puzzle? So during the visits that I recorded one, like 6/6 vision. Actually, I was testing the optotypes which in where the openings are horizontal. So I want to stress here that you have to check every orientation during assessing the visual acuity, because actually this is a misjudgment. There is no resolution of the amblyopia here in this visit, because in this visit I checked these optotypes. Yes, of course. Thanks, Dr. Maisa. And here Aswathy gives us more precise answer. It's meridional amblyopia. So to make it difficult for you, Dr. Aswathy, so what do you think is the axis of her cylinder? So she is wearing actually astigmatic glasses. So what do you think is the axis of her spectacles, the axis of the cylinder? So to make it simple and to make it easy, because this is not an optics lecture, if the patient have difficulty in the vertical, it means that his astigmatic axis is vertical. And in order to correct a vertical astigmatism, actually the cylinder should be perpendicular. So as you see here, the cylinder axis almost around 180. It was misjudged because I wasn't aware of meridional amblyopia. And here another question here for you. Covering one eye for visual acuity testing in a child, what would you use? Child's hand, caregiver's hand, patching, and occluder held by the examiner. Of course, all of these options are possible and acceptable. So you can use a child's hand, or if the child is big enough or old enough. But the best one, or the most precise and elegant one and professional one, is using the occluder, because you have a control over covering the eye properly, and also it's away from the eye. So sometimes if the child or caregivers cover one eye, he or she may press on the eye, and this causes blurring of the vision. And sometimes we need to patch the eyes if we have to stay away from the child. Suppose you want to point to the optotype at distance, or using the matching method. So all are possible, but the best one is, of course, using the occluder. So coming now to each line of treatment. First, treatment of the cause. You have to mention some examples like in form deprivation amblyopia. The cataract is a really important cause for form deprivation amblyopia. And we went through this in this tutorial and also in the first lecture on neonatal ophthalmology. And here is a question for you. Choose and complete. So regarding timing for surgical removal of visually significant pediatric cataracts, in general, the younger the child, the lesser or the greater the urgency to remove the cataract. Let's see this one. So, of course, the greater the urgency, thanks to Dr. Sana, the greater the urgency to remove the cataract. Because of what? I already mentioned, because of the risk of amblyopia, and you have to be specific, the risk form deprivation amblyopia. The next sentence here, for optimal visual development, a visually significant unilateral cataract should be removed before the age of 6 or 10 weeks, but for visually significant bilateral cataracts before the age of 10 or 12 weeks. So as you know, unilateral should be earlier than bilateral, and we are speaking about weeks, okay? So unilateral cataract should be removed before age 6 weeks, okay, 6 weeks, and for bilateral 10 weeks. So this is a kind of a checklist. You have to work on it by your own. So visually significant cataract, you have to decide whether it is visually significant or not, what are the timing for each, the procedure itself, and the visual rehabilitation after surgery. And whenever we ask someone to mention the treatment of congenital cataract, they usually stopped at the line of treatment, as the surgical line of treatment. So how about visually insignificant cataract? So suppose you have a visually insignificant cataract, or a case you can't decide for now. So you may provide the child with pharmacologic pupillary dilation. And be aware of refractive error. It could be present with cataract, so you have to correct it to avoid amblyopia. And you keep following up the child. If someone asks you about the treatment of cataract in pediatric age group, you have to cover all these lines of treatment. Don't stop at surgery. It's not all about surgery. Some cataracts are visually insignificant, and you may even discover it during the adulthood. And there was like an uncorrected refractive error, and you have some sort of amblyopia because of uncorrected refractive error. So what are the factors affecting the timing? So it's the laterality and the age of the patient. The younger, the urgency, as we just mentioned. And what are the factors, whether to the implant or not? Again, the laterality, the age of the patient, and other pathologies in the eye. So here is a checklist. So you have to work on it. So is it visually significant, and how to decide? What are the etiology? What are the timing for surgical removal, the procedure to implant or not, the management of the posterior capsule, and do we need to do anterior vitrectomy or not? How about the post-operative care, and how about the IOP monitoring for pediatric age group? And how about posterior capsular management if it wasn't done during surgery? And again, amblyopia treatment and aphakia correction after surgery if the child left aphakic. It's really important. This topic, pediatric cataracts, is very crucial to learn, study, and to be keep updated about any new lines regarding this topic. So this is just an example of treatment of the cause. The other example, if we have a refractive error. Whenever we have a refractive error in a case of amblyopia, we should give this case the refractive correction, mainly in the form of spectacles, not only for refractive amblyopia, because as we mentioned that there may be a mixed pathology in amblyopia, like we have strabismus with refractive error. So as you see here in this slide, in pediatric age group, we prefer to prescribe spectacles. So I wrote here spectacles, spectacles, and spectacles. And then there is a exclamation mark for contact lenses and 3 exclamation marks for refractive surgery, because these are the lines of refractive correction in general. And again, the topic of spectacles in pediatric age group is a big topic, and there are many considerations when prescribing spectacles. It depends on age and the indications, whether there is a refractive error only or we have also strabismus. And there are a lot of points to be covered. I shall cover some of these. So do we need to use wet refraction? Here, I mean, do we have to use cycloplegic refraction or dry? And when to prescribe? So what are the thresholds for prescribing spectacles? Factors affecting refraction. Do we need to use the retinoscope or autorefractometer? Can we use the subjective refraction? The IPD, intrapupillar distance, is really important because this child is growing up, and there will be definitely a change in the intrapupillar distance during the follow-up visits. Fitting and choosing the frame is as important as the proper prescription. And try to convince the child and parents to be compliant in wearing the spectacles full time, how to verify the spectacles during the follow-up, and the really importance of follow-up the patient. So do we need to do cycloplegic refraction in every single case in pediatric age group? Yes, no, don't know. Please don't choose don't know. Try to be decisive. You are in the exam now, and you have to say yes or no. Yes, yes, it is yes. So yes, you have to do cycloplegic refraction in pediatric age group. And why is that? So we all know this, but why? So why do we need the cycloplegic refraction in children?
Accommodation, doctor, to relax the accommodation.
Okay, so why we don't use it in adults to relax the accommodation as well?
In adults, we use a target which is 6 meters away. So they don't usually accommodate when they are fixating at the distant target. But for children, they are not attentive if you ask them to look at a distant target.
Yes, excellent. So because of cooperation, and again, because the accommodative power in children is too strong. So you need to relax the accommodation, because sometimes if you have an old kid and you do autorefractometer, for example, you may find like -3 or -5 or even 0 refraction. And after cycloplegic, you find hypermetropia, because hypermetropia can be masked by their accommodation, the power of their accommodation. So we need to do cycloplegic refraction in every single case. And what is your preferred cycloplegic eye drop? Do we need to use cyclopentolate? By the way, this is what? Parasympatholytic or parasympathomimetic. So this is cyclopentolate, or from the name, cycloplegia, it's paralysis. So it's because parasympathomimetic for meiosis and accommodation, right? By the third cranial nerve. So it is parasympatholytic. And phenylephrine is sympathomimetic. So why am I saying this? Because if we choose C, because you are using two mechanisms, parasympatholytic and sympathomimetic. For cycloplegia, actually, we use only parasympatholytic, because sympathomimetic pathway or sympathetic pathway has nothing to do with ciliary muscle, right? I want someone to give me the rationale for using phenylephrine. So again, we want to relax the ciliary muscle. So the ciliary muscle is under the influence of parasympathetic supply. All right. So we have to give a parasympatholytic drug, which is the cyclopentolate. So what is the benefit of adding phenylephrine? Because phenylephrine has nothing to do with the ciliary muscle. This is a question for you. What is the benefit of adding phenylephrine? It acts on the sympathetic system. Yes, this is the correct answer. Thank you, Dr. Aswathy, because it helps in dilatation of the pupil, because we do also need to dilate, to do indirect ophthalmoscopy, to check the fundus, to examine the fundus, to do fundoscopy. This is the main for using phenylephrine to provide dilatation of the pupil. There is another mechanism or another theory for using phenylephrine, because sometimes if the child fell into sleep, or if you are using hypnosis like chlorohydrate, there is some meiosis during sleep, which can be overcome by phenylephrine. So phenylephrine counteracts the meiosis that might occur during sleep. But if you are asked to choose one, of course you will definitely choose only cyclopentolate, because this is the drug that will act on the ciliary muscle to relax it. So suppose you have to choose one, you have to choose cyclopentolate, but the best for combined method. And we have here cyclophrine, and what are the concentration? Again, this is a basic knowledge, so you have to be aware, because sometimes in younger children, you have to dilute your eye drops, especially because of phenylephrine, because the commercially available is 10%, so you have to dilute it. This is really important if you are using the eye drops for ROP screening. You have to dilute it. So suppose you are putting the eye drops for the kids, and now what is the order? Do you check the refraction first, then fundus examination, or fundus examination, then cycloplegia? So of course refraction first, because children has a short attentive span, and they are easily to get tired or to be bored. So you have to start by cycloplegic refraction, because it needs some cooperation from the child. But fundus examination, as you know, if you are using the indirect ophthalmoscope, you can do it on an angry or crying child by forcible opening of the eyelids. So of course, cycloplegia should be first. If I ask you what are the benefits of dilating the pupil, apart from fundus examination and apart from cycloplegia and cycloplegic refraction. So we have another advantages for dilatation. First, we can use something called visioscopy. I mentioned it once in the previous part, visioscopy, to check for centric or eccentric fixation. Usually it is done after dilation. If you have an old child, for better assessment of the cataract, or if the child has cataract, or assessment of the lens in general, or the position of the lens. Sometimes if there is mild subluxation, it only evident after dilation. Only evident after dilation. So don't forget to recheck the child again on the slit lamp biomicroscope after dilation to check the lens. And now we are talking about the first visit, but again, the child is developing, the refraction is changing. So cycloplegic refraction usually repeated after 4 to 6 months during the follow-up. So what do you do to check the refraction? So what is your preferred method to check the refraction or to assess the refraction after cycloplegia? Simply, you can use the standard method, the retinoscope, the strict retinoscope, especially if you are dealing with young children or infants. So you have no option other than strict retinoscope. Some use portable autorefractometer, but again, it needs some cooperations because the child should be cooperative and fix on the target. In older children, you can use the autorefractometer as you do in adults. But I know some mentors or some professors, actually my professor, he never trusts autorefractometer. He used retinoscopy even for adults. So he is very comfortable and very confident doing retinoscopy for children and for adults. So it's a matter of preference. But for me, I use retinoscope in young children and cooperative children. But when the child is old or enough and cooperative, I use autorefractometer. She said, Dr. Subia said, strict retinoscope with free lenses. So generally, I don't use free lenses because it takes time. So we have lens rack. So it's faster to use lens rack. So suppose during your visit, the child is very uncooperative. What shall you do? Dr. Maisa, sedation. So what do you mean by sedation? Is it sedation at the clinic, or so sedation under general anesthesia or in a specialized clinic? Okay, by using the chlorohydrate. Okay, so as you see here, I wrote the 5 points. So you mentioned chlorohydrate sedation maybe at clinic, and Dr. Subia mentioned examination under general anesthesia in the OT. So we have now 2 lines. So what could be done? So we can type together this. Give sweets. Yes, okay. So giving sweets is a must in every pediatric clinic. So this is like a basic requirement. So here I will write down for you. Try your best. So you have to be patient, and every pediatric ophthalmologist should be patient. This is an important personality or personal traits in every pediatric ophthalmologist. Try your best, and you can just wait. So you may allow the child to go out and recheck again after a few minutes or like half an hour. Or you may offer the child another visit. If you feel that the case is not urgent, you can offer it another visit. And you may use the chlorohydrate, as you mentioned, and you may use examination under general anesthesia. Because 4 and 5 are not risk-free. Yes, we can use our precautions, and the child should be checked first by the pediatrician, but they are not risk-free. But trying your best or waiting for a while or having another visit are risk-free. All right. And this is an example from one of my colleagues. Sometimes the child is old and cooperative. You can examine while they are awake, or using chlorohydrate in this photo, or examination under general anesthesia. So we have some guidelines provided by the amblyopia treatment studies for treating refractive amblyopia. So what are these guidelines? First, after cycloplegia, and you already have an amblyopia based on your diagnostic criteria, full correction of astigmatism, full correction of myopia, and full correction of anisometropia. So I use here one color code because you can add here, to be clear, full cycloplegic correction of astigmatism, full cycloplegic correction of myopia, full cycloplegic correction of anisometropy. All right. And what is the missing refractive error here is hyperopia. So hyperopia, if there is an isodeviation like esotropia or esophoria, we give again the full cycloplegic refraction. All right. But if there is no isodeviation, we give undercorrection. So you undercorrect the spherical component of your refractive error. And the reduction should be symmetrical. So if you subtract 1 from the right eye, you should subtract 1 from the left eye. And the amount of subtraction varies with the age, but it should not be more than 1.5 reduction. So as you notice, we can make a general statement in this star. So I want you to read it silently and tell me there is a mistake in this statement. I made a mistake here, intended mistake. So as you see here, we will give the child full cycloplegic refraction regardless of the refractive error. The only exception is if we have hyperopia without esodivision. You have to make some reduction. So we have a mistake here in this statement. Can you point it out? Dr. Maisa pointed the correct answer here, because here I wrote hypertropia. Hypertropia. So hypertropia is a vertical squint. So please don't confuse between hyperopia or hypermetropia. So the Americans use hyperopia, British and here in Egypt we use hypermetropia. So this is a typo. It should be hyperopia or hypermetropia. Okay? Because it happens many times that sometimes in questions in exam, like there was a question about hypertropia and the student answered as hyperopia or vice versa. So we, regardless of the age, in pediatric age group, we use the cycloplegic refraction for spectacle prescription. However, in older children and cooperative children, I may use dry autorefractometer at first and have an idea about the visual acuity, the best corrected visual acuity, and then do cycloplegic autorefractometer. But again, this is to have an idea, because if you do dry, the reading from dry autorefractometer and you find the vision becomes 6.6, so this is not an amblyopia. This is just a refractive error, and it didn't lead to amblyopia. So again, in old children, I may do dry autorefractometer and have an idea about the best corrected visual acuity, but you can omit these steps and do cycloplegic refraction. So in both situations, regardless of the age, spectacles are based on cycloplegic refraction. So you need an accurate refraction. So you have to be skillful at retinoscopy, for example, and your autorefractometer should be properly calibrated. And you have to be careful during the transcription and writing the spectacle prescription, and including the interpupillary distance, it should be correct. And you have to measure it by yourself. Don't depend on the autorefractometer or any machine. Do it manually by yourself. And it's really important that the child chooses the proper frame. So we need good fitting to help in compliance, detailed instructions about the cleaning and the full-time wear of spectacles, all these things, and follow up the patient. We have special designs for friendly designs for children, like spring hangs, head straps to avoid slipping. And here there is something called ear lock to keep it fixed and avoid slipping again, because kids have a depressed nasal bridge, so it should be properly aligned in front of their pupils. And there is something called here cable temple. And as you see here, all these kids have an issue with their spectacles. So we have a broken, scratched lenses here. We have two big spectacles. So you may question that the optical center of the lens isn't in front of their pupils. We have a slippage of the spectacles here. Actually, the child here is looking above the spectacles. Again, big glasses here in bifocals. As you probably know, the line of bifocal should be bisect the pupil. So during the follow-up, you look at the fitting at first and verify the refractive power of each lens. And as you see here, there is a pressure marks on the sides of the nose. This is a tight fitting. It means that the spectacles are a little bit smaller for the age of the child, because sometimes parents keep the same glasses over years. So they don't recognize that the head is getting bigger. They need the bigger spectacle frames. All right. Big spectacles also are heavy, are liable for tilting. The same applies also for small frames. Small frames is not good because they have limited field. And as you see here, it is slipped. The child is not looking at the optical center of the lens definitely. So even with the correction, it's still small frame. So they need bigger frame. Broken frame or misaligned, or so what's the importance of all of these? Because this is one important cause for spectacle intolerance. So the child simply hates spectacles because they are not properly aligned, because they cause pain, they are scratched. And this is an example of a scratch lens. Sometimes it may be difficult for you to measure the refractive power of the lens on lensometer, or using the photometer or the lensometer, because of a lot of scratches in the lenses. You can't even see the mirrors of the lensometer. And there is nothing called part-time spectacle wear. So when it comes to refractive amblyopia or refractive correction, it should be full-time. We have part-time and full-time for patch, but spectacles should be full-time. All right. And suppose you prescribe spectacles because this is the first line of treatment for refractive amblyopia. When will you schedule the next follow-up visit? 2 weeks, 6 weeks, 6 months? So excellent, Dr. Maisa, 6 weeks. So 2 weeks are too early because it may take a few days or up to 1 week to get the spectacles from the optical shop. And we need some like a few weeks for adaptation. So usually from 6 to 8 weeks. All right. 6 months is too much because when it comes to amblyopia, time is crucial. So it needs time management. We have to spend every day wisely. So too much. 6 months is too much. So the next first follow-up should be 6 to 8 weeks. And if there is improving, and you can schedule the next follow-up from 4 to 6 months. So, but in my practice, and I really advise you to do the same, I advise parents to bring their glasses once they have taken from the optical shop before the child will actually wear them to verify the refractive power of each lens. So the child may come after 6 weeks, but I have to check the glasses after they get them from the optical shop. Maybe if there is a significant intolerance, they may schedule to come earlier than 6 weeks. So what is the effects of, so what do you think? What is the effects of spectacles on strabismus? So we prescribed here the spectacles for refractive correction, for the vision, to get the vision improved. But suppose the child has also strabismus. What do you think is the effect of the spectacles on strabismus? This is a question for you. Okay, let's watch this video while you are you think over this question. So excellent, Dr. Mesa. It gives the broader, the general answer and the correct answer according to the time. So it varies. Sometimes the spectacles improve the magnitude or the control of strabismus. Sometimes they cause strabismus. And sometimes there is no change. Actually, strabismus and spectacles is a big topic. Let's see this video at first. So as you see here, this child looks fine, like orthotropic, but on removing the glasses, the exo deviation or the exophoria becomes evident in his right eye, which is also amblyopic. And this is his refraction. He have like a high myopic astigmatism and anisometropia. So this was an example of that spectacles have a positive effect on controlling the alignment. But sometimes the opposite happens. So don't allow the strabismus to negatively affect your prescription. So suppose you are giving the child the proper prescription and there is improvement in the visual acuity. But unfortunately, the strabismus is getting worse. So ignore the strabismus because the upper hand now, or the most important now, is to improve the visual acuity. You can manage the strabismus by other lines, for example, by surgery, but the most important to improve the vision. Hopefully, improving the vision will improve the strabismus in the future. But in general, if we have an exodeviation and the myopic astigmatism or myopic refraction, this is good. Usually, the myopic correction improves the exodeviation. And usually, the hyperopic correction improves the esodeviation. But of course, there are a lot of exceptions. And according to the amblyopia treatment studies, they found no relation. Again, this is a big topic, and I just wanted to give a hint about this title. Okay, we finished the spectacles, and we have now contact lenses and refractive surgeries, usually considered if we have anisometropia for fear of anisoconia and suppression. And I skipped the contact lenses. About the refractive surgery, as you mentioned on the WhatsApp, it's highly controversial topic. Some agree, some disagree. It's very contentious. And when it comes to refractive surgery, we have many papers talking about the refractive surgery in pediatric age group, whether corneal like PRK or intraocular like phakic IOLs for high myopia, for example. And as you see, there is a lot of papers. This is just an example. And for example, this is a case referred to me because of a squint. So as you see, he has like exo and hypo in the right eye and right head tilt. Anyway, he has a dense amblyopia in the right eye and has history of anterior chamber phakic IOL surgery. And as you see, after surgery, he has some astigmatism in the right eye and some myopic astigmatism in the left eye. So he's still wearing glasses. And we offered him also patching, and even we offered him levodopa. And this is a picture of iris clue, phakic IOL from the internet, because it wasn't evident in this case, as you see here. And until now, his amblyopia is resistant, because surgery was done actually at the age of 5 years, and I think the amblyopia is already established and it is deep, very deep. So as you see here, instead of wearing spectacles and patching and the need for cosmetic squint surgery, doing this surgery added more precautions, more lines of treatment. So this child needed to avoid dropping and avoid trauma. IOP should be monitored also for iritis. And there is a concern regarding the corneal endothelium because of the anterior chamber IOL. He needed protective goggles because he has already dense amblyopia in one eye, and again, there is an anterior chamber IOL. And as you see here, the refractive surgery doesn't eliminate the potential risk for retinal detachment or even the primary open angle glaucoma, which are risks for high myopia, in cases of high myopia. So as you may feel now, I am against the refractive surgery, and here is my thoughts on this line of treatment. Because here is, I wrote about 10 points here. First, still we need patient's compliance, even after successful surgery. So even after he underwent this surgery, he needed spectacles, he needed patch. So we still need compliance. And additional care is to be given because surgery, as I said, cornea, IOP, iritis, we need monitoring for progression of myopia and refraction change. And as you see here, there is an astigmatism, so there might be an iatrogenic astigmatism or residual error. Myopic potential complications are not eliminated. Again, this is an intraocular surgery. It has or even the cornea surgery. Each has its own potential complications. And whenever you read a study about the refractive surgery, you will find this sentence: long-term safety should be studied. And as I said, usually refractive surgery is done in older kids, so the amblyopia is already established. And again, we need more follow-up visits, especially shortly after surgery, to detect any complications. And as you know, for myopia, they may need surgery for retinal detachment, for example. So this complicates the situation. And again, there is a debate about the incidence of anisoconia in axial anisometropia, because if you set the unilateral aphakia apart, mostly anisometropia axial, not refractive. So there is some debate about the magnitude of anisoconia in axial anisometropy, because children has like a high adaptability and high plasticity in their visual processing, so they can tolerate axial anisometropy. How about penalization? Penalization means punishing the sound eye. In the preferred practice pattern, they omit the word penalization and use the word occlusion, because in all the references, occlusion was a synonym for a patch. But now occlusion is becoming a synonym for penalization. So what are the line of penalization or occlusion forms? We have patch, to patch the sound eye. We have pharmacological penalization by using atropine eye drops. We have optical penalization, and we have Van-Gorter filter. These are the lines of penalization. Let's start by patching. I hadn't tried long-term patching, because even my mentors, when I was a junior, they wouldn't prescribe full-time patch. So currently, most of us use part-time patch. So if you have a unilateral severe amblyopia, how many hours do you patch? So actually, there is a study, one of the amblyopia treatment studies, compared 6-hour patch versus full-time, and they found comparable results. So it's now recommended to patch 6 hours, and it also improves the compliance. So the answer of this question is part-time patch for 6 hours. Daily, it's a daily patch, okay? Don't forget the adjective daily patch. So most amblyopia treatment studies, there are studies on moderate amblyopia, like actually from 2040, and they recommend 2 hours of daily patching. So they recommend 2 hours. And in severe, they recommend 6 hours of daily patching with 1 hour of near activities. But there is nothing to mention about very mild amblyopia. So in my practice, and there are others do the same, we prescribe 2 hours for mild, 4 hours for moderate, and 6 hours for severe. But as evidence-based medicine, they prescribe 2 hours for moderate and increase the dosage if there is no significant improvement. So it starts by 2 hours and then increase it, the dosage. So you have to know also the dynamics in the patching dosage. So you might increase the patching dosage if you need more improvement or like a faster improvement. And if there is a resolution of amblyopia, you have to decrease the patching dosage. So when we decrease the patch, or what's called weaning, what is the importance of doing this? Because we have the incidence of recurrence of amblyopia is higher if we abruptly stop the patching. So if the amblyopia is resolved, you have to decrease the patching hours gradually. So do we prescribe patching only for unilateral amblyopia? No. If you have a bilateral amblyopia but asymmetric, you may prescribe patching for the better eye. So you may patch in bilateral amblyopia, but it should be asymmetric. So what about this question? You advise patching with... So actually, it should be some activity, Dr. Sobaya. So generally, we prescribe near activities. But recently, there is studies compared the near activities versus far activities, and they found the same results. So it's not necessarily to be near activities. You can prescribe far activities. So the answer of this question, we advise patching with either, based on amblyopia treatment study in 2008. But in the earlier studies, they advise near activities only. So in my practice, I use near activities because as a reward. So because, you know, the era of the video games and mobile phones games, and every child likes this. So you patch and you do some artwork or drawing or doing your homework or playing a game. Generally, we are trying to decrease the number of spending hours on phones, but as a reward, you can give the child your mobile phone to play during patch as a reward. Which one is the ideal patch? What do you think? So I got answers B. Actually, B looks fancy, right? And pink and elegant. But the correct answer is C, actually. So the patch over the eye, if the child is wearing spectacles, so the patch should be under the spectacles, not over the spectacles. So how about this B? Because sometimes this cover is slipped and the child peeks and see from the clear lens. So usually this one is the recommended one. But for all cooperative children who are aware of their situation, they can use this one, but avoid peeking. And again, there is fancy eye patches, which is a little bit expensive. So the cheapest one is this one, the plain white one. And avoid using cotton and plasters. This is ugly. and maybe harmful to skin. So I think this is an acceptable patch. Of course, if your parents are able to buy these fancy eye patches, it maybe help in the compliance. Because of the plain nature of this eye patches, I advise my patients to draw over the patch while they are patched and show me their drawing. So it's kind of encouragement for kids. All right. So suppose you prescribed 6 hours of patching or 2 hours of patching or 4 hours of patching. So should be continuous, or it could be interrupted, like 2 hours in the morning and 2 hours at night. Actually, there is no difference, but practically I found the continuous is more easy, much more easier for kids, because the adhesive nature of the patch may harm the skin if they are repeatedly removed. And again, once the patch is removed, it's no longer used again, so it's disposable. So instead of if you use the patch twice, you will need 2 patches per day. But if you use it continuous hours, you will use 1 patch per day. So economically and for the health of the skin, I think continuous should be continuous. And the common theme in all of these pictures that they have an issue with their patch. The eyes are too big. It's actually, this is not patch for the eyes, it's patch of the cheeks and the side of the lips. Of course, this child will hit this patch. So we have different sizes for patch. This is actually an adult size, and we have pediatric size patch. So again, you have to use a proper size. If we have an irreversible organic lesion, do prescribe patches to the sound eye? Actually, there's a papers on this topic. You may try, but if you find that there is no improvement, no difference, you omit patching. Because sometimes there is superimposed amblyopia with the organic lesion. In all the books, they call it organic amblyopia. So if patching is not successful in improving visual function, you should stop it to prevent distress, because you are covering the sound eye. But again, sometimes, or like most of the times, if there is an organic lesion, there might be an associated refractive error and you have to correct it. So this is a paper about optic nerve hypoplasia or malformation, and they found superimposed amblyopia and the vision is improved with patching. As you know, there is something called latent nystagmus or latent manifest nystagmus. If you cover one eye, the nystagmus amplitude is increasing. So the foveating time is becoming less. So do we still need to patch? Can we prescribe patch? Yes, you can prescribe patch in simple ways. And we have something called eccentric fixation. Can we patch in cases of eccentric fixation? Yes, you can, but you may expect guarded prognosis. Eccentric fixation is another topic, and there are certain lines for treatment. But simply, you can patch even in eccentric fixation. And actually, there is an interesting line of treatment which is called inverse occlusion, where actually it's an old line of treatment, and it is now revisited again. So as you see here is this paper in 2019. So in summary, inverse occlusion, it means to occlude the amblyopic eye, because the amblyopic eye has eccentric fixation. There is another point other than the fovea is fixating. So you try to make the mind or the brain forget this eccentric fixation by occluding the amblyopic eye for a while. So back to your question, if we have a symmetrical amblyopia and symmetrical visual acuity, can we do alternate patching? Actually, there is a study published in Ophthalmology, and according to the results, there is no benefit. So there is no benefit of prescribing alternate occlusion in case of symmetrical isometropic amblyopia. And again, they recommend cessation of there is no need to do alternate occlusion. So this is one form of penalization, which is using the patch to the sound eye. So don't forget to the sound eye. And how about pharmacological penalization? We have atropine eye drops, 1%. And again, Previously, so I don't use this line of treatment, but anyway, it is an important line of treatment, and sometimes it is the first line of treatment instead of patch. So traditionally, they recommend using daily atropine because it blurred the near vision. Sometimes it is augmented by using a plano lens for the sound eye. So again, I will repeat this one again. So if you are using atropine, again, atropine eye drops to the sound eye. So it causes blurring to the blurring of near vision of the sound eye. And sometimes they add augmentation by prescribing plano lens to the sound eye. So if the sound eye has hyperopic refractive error, so imagine now that the sound eye has hypermetropic refractive error, and you give it plano lens. So this is called optical penalization. So two things happen to the sound eye. So sound eye is penalized by two things: giving optical penalization by plano lens, because it needed the hyperopic refraction. So you give it plano lens. This is optical penalization, and we use pharmacological penalization. So pharmacological causes blurring of the near vision, and the plano lens causes blurring of the distant vision. But actually, this line of treatment augmentation was used with weekend atropine, because another study showed that weekend atropine has similar results as daily atropine. So currently, they recommend using atropine on weekends. This is the answer of these questions. What is the regimen for atropine eye drops penalization? So traditionally it was daily, but nowadays it is twice per week on the weekends. And as you know, in the US, the weekends are Saturday and Sunday. All right. And fill in the gaps. You answer it correctly on the WhatsApp. Just a little hint about this atropine sulfate. The concentration is 1%, or if you say it in milligram per milliliter, it is 10 milligram per milliliter, and it is psychoplegic mediatic. So I want you to notice that parasympathetic have both psychoplegia and mydriatic effect, but sympathomimetics have only mydriatic effect. So again, traditionally or previously, they prescribe atropine eye drops only for moderate amblyopia, but currently you may try it in severe amblyopia as well. Again, nothing are approved for has like FDA approval for amblyopia treatment. They are unapproved drugs. So atropine or levodopa. So we will mention levodopa in a moment. So atropine and levodopa are used for amblyopia treatment as off-label, but they don't have they are FDA approved as drugs, but they don't have FDA approval for amblyopia treatment. So we call it off-label use. Regarding the optical penalizations, we already mentioned the optical penalizations as an augmentation with the atropine eye drops. We have the Bangerter filter. It's a kind of filter that degrades the vision or defocus the image, and it should be placed on spectacles, so the child should be wearing spectacles, and we have like grades according to the density of amblyopia in the other eye. And it's full-time wear, so it's kind of full-time wear because it's already on the spectacle lens, and the spectacles, as you know, is full-time. So again, here next is the combined. So we have combined line of treatments. So suppose you have an isometropic dense amblyopia. What is your order? And I think we mentioned it. We prescribe spectacles first, because according to the amblyopia treatment studies, spectacles alone can correct the amblyopia. But if there is no improvement or no resolution, you have to add patch. So the correct answer here is spectacles, then patch, provided that the patient is not wearing spectacles before. But if suppose the child, so this is important. So suppose the child already you are seeing a child for the first time with anisotropic dense amblyopia, but he is already wearing spectacles. So in your first visit, you prescribe patch. So you have to discriminate between two conditions. If the child is already wearing spectacles, from the first visit, you add patch. But if the child is not previously wearing spectacles, you prescribe spectacles at first. So to see the results and to get the compliance with the spectacles wear, and then add patch if there is no improvement or no significant improvement. You have to add patch. All right. So as is in this case, this child has a refractive error. And if you notice in this slide, this is the cover of his file. And see, sometimes I draw some symbols. So here, as you see here, I draw spectacles, then there is an arrow, and then a patch. This means that the child was given spectacles, and during the follow-up, I added the patch. I added patch. And here, if you notice this, the date for spectacles, and this is the date for patch. So this is the same child. So what is the expected refractive state based on this photo? Yes, it's a Procknell test. So because of asymmetry in the read reflex, you said anisometropia, and this is correct. But again, if we have anisometropic what? Anisometropic hyperopia or myopia or astigmatism? What do you think? As you see here, there is a bright crescent. The read reflex is not uniform or not diffuse. It's like a crescent up. And here again, the brightest area here is up. So if there is a bright crescent up, this is hyperopic refraction. So this is hyperopic. So try to make a mnemonic here. Hyperopia, like a hyper, like something up. So if you check the Bruckner test, or actually this is a mobile photo by the flash on after the pupil is dilated. And here the crescent is up, so this is hyperopic refractive error. So actually B is true and D is true also. So this child has hyperopic refraction, but it is more higher in the right eye. And that's why the right eye is amblyopic, and he's giving glasses, and later on he is giving a patch of the sound eye. And as you notice also, there is a change in the frame because this is over follow-up visits. An example of combined is the use of the spectacles and patch. Another line of combined, the use of patch, part-time patch, of course, and atropine eye drops. So we penalize the sound eye by two mechanisms, a part-time patch and atropine eye drops. Another form of combined, as we already mentioned, the weekend atropine eye drops with a plano lens for the sound eye, which has a hypermetropic refractive error. Coming to the other lines, levodopa or L-dopa, in some books, they call it pharmacological therapy. So in national exam, in our national exams, if the examiner asks you about the pharmacological therapy for amblyopia, they usually want to mention the L-dopa. However, this word, the pharmacological, was mentioned with atropine eye drops. So supposing you are in a situation and you don't know, if you have been asked about the pharmacological therapy, you can mention topical as atropine eye drops and systemic as L-dopa. So you cover all the possibilities about what do they mean by pharmacological therapy. By the way, this is not mentioned in American Academy because one of the amblyopia treatment study found insignificant use of L-dopa. Personally, I use it for resistant amblyopia, and it wasn't effective. But if you Google for it, you will find some papers talking about the some improvement by L-dopa even in adults. And we have vision therapy or binocular treatment using the iPad or dioptic therapy. And here is the study, as I mentioned, about the L-dopa. So adding the levodopa doesn't produce any meaningful improvement. And this may be the reason for ignoring this line of treatment in the American Academy. But again, here is the other side. Some people are talking about the improvement by L-Dopa. Dioptic treatment, you can Google it and you can check YouTube. You will find a lot of materials like articles and videos talking about dioptic treatment or training. From the etymological point of view, di means two because each eye has a view or seeing a picture from different perspective. Generally, it's not a kind of stimulation of the amblyopia eye while both eyes are open. So that's why it's called binocular treatment or binocular treatment. And be careful, the last point here about the treatment. And if you have a significant refractive error like high myopia, the care for the patient goes beyond vision. They are liable for retinal detachment later on in their lives. So sometimes you have to keep notice or to educate parents about the risk of having our retinal detachment in the future. So if they have any symptoms suggested of retinal detachment, they should seek a medical advice urgently. And this is one of the benefits of patching, actually, because as you know, if we have anisometropia, like dense amblyopic anisometropia, and both eyes are open, the patient maybe not recognize that there is a retinal detachment in this eye because he already dependent on the sound eye. But if the sound eye is patched, they will be aware about if there is any problem in the amblyopic eye. Here I added in this slide, the final slide here, about what's called alternative treatment. What does this mean? Sometimes you prescribed patch, but there is no compliance with patch. So you substitute patch and use alternate line of treatment like atropine. So this is like a concept here in the treatment of amblyopia called alternative treatment. Okay, so just a little hint about the screening. So simply you can screen for amblyopia, assessing the visual acuity and searching for the risk factors. The most important one is looking for significant refractive error. So here we are screening for any refractive error. And again, there is some guidelines for the threshold for prescribing glasses in pediatric age group. The Academy has published treatment guidelines for refractive correction in infants and young children in this table. So kindly, I want you to take note of some important points here related to this table. First off, the title itself. Guidelines just guide you, but there are no hard and fast rules on that topic. You are the only person who takes responsibility for your patients. And as you see here, in this part of the table, there are only 3 age groups. There are only 3 pediatric age groups, less than 1 year, from 1 to 2 years, and finally from 2 to 3 years. So what about the remaining age groups? Because as you know, pediatric age groups are up to 16 or even 18 years old. So we will see in a moment. Second point here, whenever there is a note below the table, you must read it carefully. It usually contains information that is as important as the contents of the table itself. Here I underline an important sentence here that says that the guidelines for older children are not provided because the refractive correction is determined not only by the severity of the refractive error, but also the visual acuity and visual symptoms. Because we expect that after this age group, the child is old enough and cooperative, so we can test the visual acuity more accurately and document whether there is an amblyopia or not. And also we can take a reliable history from parents regarding any visual symptoms. Now, let's see this part of the table. which divides the refractive errors into two main groups: isoametropia, in which there is similar refractive error in both eyes, and anisometropia, in which there is a difference in the refractive error between both eyes. And each one is further subdivided according to the refractive error into myopia, hyperopia, or astigmatism. So my second point here regarding the numbers in this table. So for example, for myopia, in this age group, less than 1 year, the threshold for prescribing spectacles is -5 or more. So you may be surprised, why -5? Because at this age group, the environment for that infant is very close. They don't really want to look at distance. They're still too young to look at distance. So as you see here, as the child gets older, the threshold, the numbers are decreasing. And that's why I draw this graph for you. So as you see here, suppose this is the age. So this is the x-axis. So as the child gets older, the threshold for prescribing spectacles, or the number, is decreasing. And here, note the effect of having ESO deviation in hyperopia. So the threshold for prescribing spectacles in hyperopic refraction is lower if there is an ESO deviation, incomparable to hyperopia without ESO deviation. And as you know, the hyperopia is the expected refractive error in this age group. However, we can prescribe spectacles 2 + 5 or more in this age group if there is esotropia. Furthermore, usually the threshold for astigmatism is lower also, incomparable to myopia or hyperopia without ESO deviation. And if we compare isoametropia versus anisometropia, we will find that the numbers are lower in anisometropia versus isoametropia. Another crucial point here regarding numbers, in isoametropic group, the numbers here represent the amount of refractive error, the refractive error you found in cyclic refraction. However, in an isometropic group, the numbers here represent the minimum difference in the magnitude of refractive error between both eyes. And this is actually written here in the note below the table. Last point here, or my last comment on this slide, whether you prescribe spectacles or not, you have to keep following up with the child. For example, suppose you found like -5 in this age group. And now the child is, let's say, 5 years old, like older. And the myopia is the same or even worse. Then you have to prescribe glasses. And I forgot to mention that in anisometropia, there is no mention of the effect of having strabismus. So here we have an asterisk. It says that anisometropia without strabismus. Of course, if there is a strabismus, the numbers, you have to decrease or lower your numbers or lower your threshold for prescribing spectacles. Show you some photos, nice photos from India for the campaigns for screening. So the screening could be comprehensive, including, as you see here, examination, doing retinoscopy, and so on. So Dr. Subaya, your question is about the atropine in high myopia, right? So this is another topic, using the atropine in high myopia. I like compilation questions, like what are the indication of using atropine in pediatric age group or in ophthalmology? So we use atropine for like amblyopia, as you mentioned, we can use atropine, but the diluted form of atropine for help decreasing the progression of myopia. And this is another debatable topic also. Again, back to our point here. So we can use what's called photo screening, which is based on the Bruckner test. But be aware that abnormalities in the Bruckner test or in the red reflex, it depends on many factors, not only the refractive error, but also on strabismus. And whenever we have a strabismus, the fixating eye give a dim reflex because it's fixating, it is myotic, but the squinting eye gives brighter red reflex. And this is an MCQ question. So if we have a squint, the squinting eye gives us brighter red reflex. And of course, the red reflex also affected by other media opacities like cataract, like lateral attachment. So many factors affecting the red reflex. Refractive error, organic lesions, and strabismus. And they do photo screening by specialized machines. And here is a clip about photo screening in the United States. So as you see here, the machine is away from the child, and the child is asked to look at a specific target, and it is a kind of screening. So we don't use these machines for prescribing spectacles, but just for screen. And it provides us with what is the refractive error and so on. And during the pandemic, they use foot screen like this, very impressive. And again, there is in the United States another app for Bruckner tests and to check the refractive error. But again, this is only for screening because, as you know, screening test should be non-invasive, should be rapid, but it's not that much specific or sensitive. So you have false positive and you have false negative results. So screening could be at the level of the government or by authorities at the larger scale, or could be individualized. So in your clinic, you can screen at least the other siblings. So this child has both accommodative, some sort of accommodative esotropia in the left eye here, and she has also amblyopia in the left eye, and she is a twin. She has, so I checked her sister and her younger sister, and both all have refractive errors, and they are corrected accordingly. So you can screen at the lower scale by asking about the situation for siblings, and you may check them as well. The last but not least, Dr. Aswathy. So she kindly accepted to do like a PowerPoint presentation from 2 to 5 minutes about the electrophysiology in amblyopia. Are you ready, Dr. Aswathy?
Yes, ma'am.
Okay. I stop share my presentation and you can share yours.
Okay, shall I start now?
Yes, you can.
The electrophysiological tests are used to study usually the mechanism of decreased visual acuity and the location of major defects and their depth. And these provide an assessment of the complete visual pathway extending from the ganglion cells to the occipital cortex. So we use mainly two electrophysiological tests, the VEP and the ERG. The visually evoked potential of the VEP, they record the activity of the primary visual cortex in response to visual stimuli and is one of the current techniques used to understand the complicated mechanisms of amblyopia. Here, the electrical potentials, which are initiated by brief visual stimuli, are recorded from the scalp overlying the visual cortex. And the VEP waveforms are extracted from the EEG by signal averaging. So we present, there are three types of stimuli, the pattern reversal, pattern onset, and the flash stimuli. Of this, the most common stimulus we use is the checkerboard pattern, which reverses every half a second. That is the pattern reversal stimuli, because there is more inter-subject VEP reliability in this case than with flash or pattern onset stimuli. So in a recording of the VEP, we have first a prominent negative component at 70 milliseconds, then a large positive wave at 100 milliseconds, and then a more variable negative component at about 140 milliseconds. So this P100 or the positive wave at 100 milliseconds is the most important parameter in a VEP. This only slows about 1 millisecond per decade from 5-year-old to 60-year-old. So it's fairly constant measure. The retinal development, cortical cell density, myelination, and the visual acuity are close enough to that of an adult by the age of 5 years. So children at this age can produce an adult VEP form. Actually, by 3 years itself, the child can produce an adult VEP form, but at that age, the fixation is the problem. In those cases, it's better use the flash VEP. Generally, the latency may vary 2 to 5%, but the amplitude will vary may up to 25%. So, latency is a more reliable variable. So, pattern VP is generally used for detection of visual function disability or also for the objective visual acuity assessment. And what we see in amblyopia, from all the studies, what we see in amblyopia is generally a decrease in the amplitude of P100 and prolongation of the latency. So as we know, there are two types of mainly the ganglion cells. There are Y ganglions and X ganglions. The Y ganglions in the retina collect responses of various cones, and they have a fast and temporary response, and are related with motion and three-dimensional vision. And the X ganglions receive output of different cones and are related with color, structure, and shape vision. The Y ganglions relate to the magnocellular part of the lateral geniculate nucleus, whereas the X ganglions relate to the parvocellular part. And the high visual acuity of fovea was provided by the X ganglion cells. And it is the X ganglion cells which are mainly affected in amblyopia because of this structured visual deficit during the early critical development period. The parvocellular pathways are sensitive to high spatial frequency stimuli and low temporal frequencies, while magnocellular pathways are sensitive to low spatial frequency stimuli and high temporal frequencies. So, it is able to differentially study these two things by altering the spatial and the temporal frequencies. And it is found, and in some studies, it says that in amblyopia, both the parvocellular and magnocellular pathways are affected. But some studies say that the magnocellular pathways are relatively spared in amblyopia, while the parvocellular pathways are affected mainly. And another use of VEP is that successfully treated amblyopic eyes shows a significantly lower latency than the normal eyes with small check stimulation. And also that the non-amblyopic fellow eye, they also showed significantly longer latency than did the normal eyes, suggesting that there is some altered central processing. Now, in multifocal VEP, it was noticed that the latencies were more delayed in anisometropic eyes than in strabismic eyes, suggesting that anisometropic and strabismic amblyopia may represent different neural abnormalities. And the P100 amplitude of the pattern VEP test parallel the improvement in the subjective visual acuity in amblyopic eyes under the occlusion therapy. Now, another finding is that in esotropic amblyopia, the multifocal VEP latency is prolonged and the amplitude is also reduced in the central region of the visual field, but is more significantly so in the temporal visual field than in the nasal visual field. But in comparison, in anisometropic amblyopia, this defect was attenuated in the central region of the visual field, but the effect lessened towards the periphery. And when studied using a flash VEP, the strabismic amblyopes, but not the anisometropic amblyopes, often showed supranormal responses in the affected eye at higher temporal frequencies. Now, as I said, it was also used in estimating the visual acuity. The visual acuity can be estimated by altering the check size. And the VEP results generally agreed with the Snellen, Allen, and E acuity measurements more often than the forced preferential looking tests. But in amblyopia, the acuity can be markedly overestimated using a VEP. And one study says that the pre-amblyopic therapy sweep VEP acuity can be a good predictor of post-amblyopic therapy Snellen's acuity. Now, that's all about VEPs. Coming to ERGs, in literature, there is no consensus on ERG results of amblyopia cases, and this may be attributed to different study designs, inclusion criteria of cases, and different electrophysiology devices. But there are some studies which argue that there is a reduction in PERG in amblyopia without a corresponding reduction in the focal ERG, and this reduction may differ according to the type of amblyopia. And also, with occlusion therapy, the contralateral eyes showed a decrease in PERG amplitudes by iatrogenic deprivation, and improvement of visual acuity by occlusion therapy was correlated with an improvement in PERG amplitude. But when there was no improvement in the visual acuity, the PERG amplitude remained low. That's all I could find about the electrophysiological test in amblyopia.
Thank you, Dr. Aswathy. Your assignment was tough, but you did a great presentation. You did an awesome job in this presentation. Thank you.
Thank you, ma'am.
So back again to my presentation. We're almost about to finish. So I have a case that sometime I order electrophysiological studies to exclude hidden pathology and to confirm my diagnosis. And usually we depend on the pattern visual acuity, pattern VEP. And as you see here, she did one of our eminent professors in this field. She did a pattern VEP and something called binocular pattern VEP. And the impression, she mentioned that she confirmed my diagnosis that the right eye or one eye is amblyopic, and there is no other pathologies. And I posed this question because I got almost a correct answer, because I think Dr. Aswathy learned a lot during her assignment, and she refreshed her knowledge about the topic of electrophysiology in general. But she went, I'm sure that she spent a lot of time because she went across many papers, and there is some confusing terms and some contradiction regarding the electrophysiology in amblyopia. It needs a very skillful operator to give you a well-written and helpful report. So generally, ERG. So this is a basic knowledge, and sometimes they come in MCQ in the first part of FRCS or ICO exams. So ERG is tested monocularly because we have electrodes for each eye. So here an electrode in the right eye, and the operator is going to put the other one, but I photographed this photo before she put in the other eye. So both eyes are open in doing ERG. In VEP, it is tested monocularly. So if we are doing the VEP for the right eye, we cover the left eye. But for amblyopia, we may test both eyes open. So VEP could be monocularly or binocularly. Generally, monocularly, sometimes binocularly, right? So investigations in amblyopia could be electrophysiological studies. There is something called psychophysical studies like contrast sensitivity, for example, color vision. Sometimes others order OCT or OCT angiography. There is some reports about structural changes in the retina in amblyopic eyes, also to exclude other hidden pathology. MRI, again, to exclude organic lesion. So if you are suspecting of something else, you may order the pertinent investigation. The last part in our presentation, the quiz time. We have two videos here. All right, so let's concentrate on the first one. So, what is your comment on this video? This is an alternate cover test. and you see movements. So the video once more. The patient is fixating on a target, and I'm doing alternate cover test. Okay, so we have the movement here is iso. So no need to mention alternative isophoria. Once you say isophoria, just isophoria without laterality. So let's say it's an isophoria. But by the way, whenever there is an alternate cover test, you can say isodeviation, because to differentiate between isophoria and isotropia, you have to do cover and cover test. But alternate cover cannot differentiate between tropia and phoria. But let's say it isophoria, okay? And now look at the Dr. Subia. Now look at the other video. Now the child is wearing glasses, all right? So what do you see now, Dr. Subia? Now the child is wearing, the girl is wearing glasses.
I see exodeviation.
Exodeviation, so that's correct. So we can say that the spectacles like reverse the type of deviation. Like instead of isophoria, it becomes exophoria. And I will tell you another piece of information here. The spectacles are hyperopic. So do you have an idea about the diagnosis? So this child actually has a diagnosis of accommodative esotropia, and she was giving full psychoplegic hyperopic correction. And in one follow-up, she developed exodeviation by spectacles. So what is your diagnosis here? So I will answer it, because I mentioned this. This is an example on how the spectacles can affect the strabismus. So for accommodative esotropia, we prescribe full psychoplegic refraction, as you know. But over times, if we have to do what's called weaning. So this is the second time to mention weaning here. We mentioned weaning when we stopped the patching for amblyopia after a resolution of the amblyopia. And now we have to do what's called weaning of the hyperopic correction. So once we get control over the accommodative esotropia, over time, we have to decrease the plus in their glasses. Otherwise, they may develop exodeviation, especially if there is some sort of amblyopia. So in strabismus, we have weaning for plus correction for accommodative esotropia. And this is an important topic. And that's why when we are prescribing spectacles for children, we have to check the alignment. We have to do alignment check. So there is no way to escape from strabismus here. Screening, I screened her younger sister, and she has also accommodative esotropia. And as you see here, right, esotropia, and she's giving her hyperopic correction, the full psychoplegic correction. And over time, when the child gets older and there is a better control, we can wean or decrease the plus power in the spectacles. So this was the quiz number 1. Quiz number 2 here. I'm showing you a video, and you will mention what is the test. So excellent. This is not direct ophthalmoscopy. This is called visuoscopy. And as you see, when you check the fixation pattern, whether it is eccentric or centric, you have to cover the other eye, and you have to ask the subject or the patient to look at the center of the circles. Usually we do it after dilation, but because this is not a patient, this is a volunteer, so we just turn off the lights, and that's why the video is dim. And after I remove the ophthalmoscope, if you notice in this dim picture, the eye is out because he is actually looking at the center of the circles. So generally, when we are doing direct ophthalmoscopy, we ask the patient to look at far, but here in visuoscopy, we ask the patient to look at the center of the circles. And the last quiz here, actually, I posted like a month ago on WhatsApp. Let's have some fun here. What's the favorite English letter for an ophthalmologist and why? And I got the answer C, because C, this is how we see things, but also I is a nice letter. So I is a pronoun for ourselves and also a homophone with our eyes. Okay, Dr. Kirsana, to your questions, you can say for 6 months, for example, but according to studies, if there's some improvement, they keep improving slowly. So my message is don't quit or don't lose faith, because as you read a lot about the amblyopia treatment studies, you will find a lot of exceptions. And in the recorded version, I will post the links for an important article talking about failure and like the action plan for failure of amblyopia or resistant amblyopia. Because in this presentation, I mentioned just the key points, not everything. All right, Dr. Kirtana. And you can combine both letter IC, and we have CC for corrected vision, and we have the chart, Landau C chart, and what is the coincidence? There is another joke regarding the favorite letter for the pirate, and the pirate also likes the letter C because of the C here, the homophone with C-double-E, and sometimes we call the patch for amblyopia as a pirate patch. So I hope I make some clarifying points here. There is a lot of questions, of course, left, and you have to work it on your own and with your seniors. Finally, I hope my message has reached about the avoiding missing the diagnosis or mistreat amblyopia. And don't forget the line of treatment and this acronym Save Our Sight. And I think if you read it now from Kanitsky, our beloved book, it will be like a piece of cake. Actually, the American Academy published a lot of preferred practice patterns, not only for amblyopia, or there is others for other topics. You can check by yourself. And this is a kind of an evidence-based medicine. And as I mentioned to Dr. Kirtana, never lose hope, because now they are trying to treat amblyopia in an adult. So don't lose hope. There might be a non-compliance. You may need to add another lines, use the combined methods. And that's why little learning is a dangerous thing. That's why we have to keep learning and to keep update our knowledge. And I think this is the end of our presentation. I really appreciate again those who have a share in this presentation. Dr. Naveed, Dr. Kirtana, Dr. Hala, Dr. Sana, and Dr. Aswathy. And that's it. Stay active, stay alive, and study attentively. And try to practice what you learn. And if you have any questions or consultation, you can reach me at my email.